Dr. Scovell, Field Scovell, thanks for joining us today. Yeah. Everybody, joined by my co-host Tyler Tallman. We're here today on the cutting edge to talk advancements in shoulder surgery and shoulder replacement. Sounds kind of good. A interesting topic for us sports nuts. So we're gonna cover a number of items today, Dr. Scovell, if that's okay with you.
Yeah, sounds good.
Nothing super structured, but right. I think this will be a fun conversation because we're also into Masters Week, and we're going to talk a little Masters discussion with some high-speed activity at the end with Bryson D Chambeau.
Sounds good.
Let's lead off. Just tell us a little bit about your personal and professional background.
Yeah, well, I born and raised in Dallas, grew up here, and went to Hillcrest High School. Ended up going to Texas Tech, played football there for Coach Dykes, and then went to med school. And before med school, thought I wanted to be an orthopedic surgeon. A lot of orthopedic surgeons have an injury story where they got hurt, met an orthopedic surgeon, got into that. I got hurt. I hit a tree skiing in the 7th grade, which is another story. Met a guy, Dr. Knight, Marvin Knight, his dad was the Cowboys physician for a while. He was in practice, went to see him, just wear a brace, get better. Not a big deal, but I had to miss indoor soccer season, which at the time was the most important thing in the world. And then this doctor, got me back to indoor soccer, which I could care less about indoor soccer. But at the time, it was real important. So I thought, man, this is cool. This is a cool job. And then when I was at Tech playing football, the team physician is a guy named Dr. King, Rob King, whose dad was my father's coach at Tech. So long-time Tech connection there, but Rob King and I were personal friends, our team physician. Rob, I told him I was interested. Dr. King said, well, come hang out with me, and I'll show you what's going on. And, of course, I saw him every day because he came by practice and he was at our games and he was traveling with us on the road. And I'm like, this would be a cool gig. Cover a college team, get to go to all the games, So at Tech, majored in finance, but took all the prereqs, got into med school, always knowing I wanted to be an orthopedic surgeon. It's funny, I wanted to be an orthopedic surgeon before I knew they were doctors. So I was like, well, you got to go to med school. So anyway, pursued the path. Got into med school, got into orthopedics.
So hold on. So how did that jive with being on the football team? Because I know as a former student athlete that there's huge time demands.
Yeah, I was pretty fortunate. I was pretty fortunate because I placed out of a lot of stuff. So I didn't have to tack on a bunch of hours. I could just fill in. I didn't have to take math and history and English and all that stuff. I'd already kind of been done with that. So
what position did you play?
I was a receiver at Tech.
Okay. And did you come from a long lineage of doctors in your family?
No, I had a veterinarian.
Okay.
My grandfather's a vet.
All right.
I think that's it, really.
So the first orthopedic surgeon then?
Yeah. First orthopedic surgeon, first doctor, first medical doctor.
Very cool.
And so, it was a challenge, but it worked. Schedule-wise, it worked out. On occasion, you might miss part of a practice for a lab. I do remember missing a scrimmage in the spring because I had to take the MCAT, which is kind of but Coach Dykes and those guys were great about it. Look, I wasn't the star player, so maybe me missing wasn't that big a deal.
Yeah.
I got to play a lot, and I contributed, but so maybe looking back, it was like, you're okay.
You have a career highlight catch?
I caught a touchdown at Penn State.
Oh, man.
Yeah, it was big time.
And what years was this?
This was 95. I played 92, 96.
Okay.
In 95, I went and played Penn State. So my family has a long history in college football and connections with the Cotton Bowl. My grandfather helped start the Cotton Bowl. So Joe Paterno was a buddy of his from back in the day. When the Cotton Bowl used to be where the Southwest Conference champion would play in the Cotton Bowl.
Yeah.
And then the bowl committee would go out and get another team to commit to play the champion of the Southwest Conference. My grandfather was the head of the selection committee, so he was the guy on the road talking with ADs, talking with football coaches, and meeting all these guys, making friends, and then basically it was a sales job. Hey, come and play in the Cotton Bowl, and here's why. Well, he was good at it, and so he made a ton of friends in college football. Joe Paterno being one of them. So 95 are playing at Penn State, Happy Valley, awesome stadium, awesome environment, and we're warming up, and I hear somebody's calling my name, Scovell, and so turn my head around, it's Coach Paterno, and
Wow.
I was like, Coach? So my buddies are over there, and they're like, yeah, this is BS. Coach Paterno knows this guy. Coach Paterno said, hey, man, we're real proud of you. Happy that you're here and stuff. And congratulations and all that stuff. And then caught a touchdown, which is cool. So I digress. That was my highlight of my college football career. And then, anyway, got into med school, got into orthopedics, pursued sports medicine. Practiced in Lubbock for 10 years. So come full circle, when I got out of fellowship, sports medicine, I was looking for jobs, had an opportunity here in Dallas at the Carroll Clinic, and had an opportunity in Lubbock at a place called Lubbock Sports Medicine where Dr. King still worked. They took care of the team still. So the first job out of the gate was move to Lubbock, take a job at Lubbock Sports Medicine, and you're a team physician, which was great. It's my alma mater, grew up loving tech, and boom, right there on the sideline. So the job that I thought I wanted, I ended up getting, which is really cool.
Wow, how rare is that? I mean, that just...
Well, it was unbelievable.
My gosh.
Now, then you learn pretty quickly, this is not all fun and games.
Yeah.
I'm not just going to games and hanging out and, in the locker room, taking care of kids, taking care of players. There's a lot of stuff a lot of it's a pain. But it was a great experience. Ended up taking care of the basketball teams. So then, and the most recent experience before we moved back was Coach Beard comes to Lubbock, Elite 8, Sweet 16, Final Four, all the stuff. So we all of a sudden just had this great success. That was a lot of fun to be a part of. And then ultimately moved back to Dallas, and then another opportunity arose at the Carroll Clinic, and took a job there. Moved back home just to be closer to family. So that's it. That's my career path.
And that's a heck of a career path. I mean, you mentioned fellowship. So what led you to pursuing a fellowship to specialize in shoulders?
Well, most of I knew that I wanted to do sports medicine, and that fellowship that I did was sports medicine and shoulder reconstruction. So it was a guy named Dr. Richard Hawkins.
Oh yeah, well known.
Well-known shoulder surgeon and also sports medicine. So
Stedman Hawkins Clinic.
So there's a Stedman Hawkins Clinic in Vail, long time.
Yeah. That
Dr. Stedman and Dr. Hawkins were the names, and then they expanded to South Carolina and opened a clinic in Spartanburg, Greenville area.
Okay.
And so Dr. Hawkins went to South Carolina, Dr. Stedman stayed in Vail, and then we had an opportunity to either go to Vail or South Carolina, and I just fell in love with Dr. Hawkins, really. A guy named Dr. Singleton, Steve Singleton, who's in Fort Worth, he was a part of that at the time. Just felt like those are the guys I'd want to learn from. So then moved to South Carolina and then completed that fellowship. And really, these days, if you're going to be a sports medicine guy, a shoulder guy, you need that one extra year of that fellowship training. It's another, plaque on the wall, that people recognize. Okay, this guy's a sports expert. He's a shoulder expert. So we want to go see him. So, and if you're going to take care of teams, if you want to do any kind of significant level athletics, taking care of that, you really need that fellowship and that experience. So.
It's terrific. I bet you got to see a lot of gruesome injuries being on the sidelines. Any wild stories you can remember from that? Anything that made you rethink your career path?
I saw in residency. I saw a lot more gruesome injuries at Parkland Hospital than I did in sports. But you do see some nasty knee injuries. Usually, there's not blood squirting everywhere, but you'll go out there and you're like, that ankle is not supposed to be pointed that way, So several occasions where you're going out there and either the shoulder is dislocated, or in one instance, the kneecap was dislocated, or the ankle's dislocated, and you're out there and the stadium's dead quiet, and there's lots of eyes on you while you're out there. And you're like, all right, pal, this is what we're gonna do. We're gonna just pull this back into place. Might hurt a little bit. Sometimes you're running the truck out there and getting them off the sideline and going up in the locker room to do that.
Yeah.
Sometimes you're probably ought to put this right in, right here.
Yeah.
So
You said you did residency at Parkland.
yeah,
Yeah, so
Yeah,
that was probably an interesting experience as well.
that was a crazy experience. It was just nuts from the start, and it's OJT, man, on the job training.
Yeah.
You show up and you're like, hey, go down the ER and take care of that.
Yeah.
Broken wrists, broken ankles, whatever. You just got to learn on the fly. You just don't have the time. The volume is such that you have to figure it out. So you learn a lot real quick, whether that's, putting wrists back in place and reducing fractures and closing wounds and, all right, look, we got to go to the OR. We got to go fast and just handling all that stuff. So it was a great experience. You do see some nasty stuff in that ER, and that you see a variety of things that are, it can be, there's some vomit-worthy moments down there.
Yeah.
Wow.
Well, so let's pivot a little bit here and let's talk, shoulder-specific injuries. And our audience is kind of a mix of your colleagues and healthcare professionals as well as just general public. I think there's a lot of interest around advancements in shoulder surgery.
Yeah.
We think about what's gone on in total joint replacement and the inclusion of robotics and how people are up and moving the day of surgery, and all of a sudden they're back to normal in 4 to 6 weeks. Compare what's going on in kind of shoulder reconstruction and shoulder replacements relative to knees and hips, for example.
Well, in general, the big advancements have been made in all joint replacements and just components and materials, and they last longer. Survivorship of the implant is really key for any joint replacement. So those materials have gotten better. And then the way to fix those materials, the way to basically, if you're going to put in a joint replacement into the shoulder or into the knee or hip, that part has got to stick, right? It's got to stay there. It can't get loose over time. So that has advanced significantly over the last, 50 years, even longer for hip and knees. So the components have gotten better. And then, as you mentioned, you're getting this robot-guided surgery. The surgery and the procedure itself, both hip and knee, but also shoulder, have gotten more precise. So your shoulder and my shoulder are the same joint, ball and socket, rotator cuff, subscap, biceps tendon, ligaments and stuff. So that's the same, but the size is different. The tension is different. Your range of motion may be different. So we need to tailor that to your shoulder. So what the parts that you get will be different than mine. So that the material has gotten better, and then the fixation has gotten better, and then the specificity has gotten better. So in hips and knees, they're doing a lot of this robot guided stuff, and they're doing this basically where you get a pre-op CT scan that maps out your bones and structure, and then you're going to get components specific to that knee. So they're going to, in some cases, 3D print a femoral component that matches your anatomy. And then this robot guided tools where they're making these cuts on the end of these bones perfectly to match that component. So the fit is you. It's unique to you.
So how has that changed the OR for someone like you when you've got all these robots and all this stuff going on? It's so different than it was 10 or 15 years ago. So walk us through that, what that looks like.
I don't do hips and knees necessarily. So that robot, but there's all this new equipment in there, right? So you've got to learn how to use it and that kind of stuff. And then there's somebody's got to be there to help you use the equipment. So I would say there just seems to be more people and more stuff in the OR, And so the idea behind that is precision, better fit, quicker surgery, more accurate surgery, less time figuring out is this a 3 or is this a 4. You just kind of know. Going in, make the cuts and stuff like that. That's much more involved in hip and knee surgery than shoulder surgery. It's coming along, so we don't do robot guided shoulder surgery, but the advancements there, like same thing, CT scan of the shoulder, mapping out your bony anatomy, and then you get these, and then kind of they tell you before you ever go in, hey, look, this is going to be a 28 head with a small glenoid, and this is where it needs to be put. So you kind of go in with a game plan, and previously, like, you'd have an x-ray and you might just size it, and so you take a 1, a 2, a 3, a 2. 2's better, right? Probably going to be a 2. Well, when you get in the operating room, you're still going to look at it again, but you kind of have an idea. Now it's like CT scan, get an email, check it, and then you can play with it. So you can kind of move the humeral head where you might want to put it on the software, using the software, or move the glenoid around, the glenoid component. You can move it around the socket and say, okay, and so the software tells you, hey, this is where it best fits according to the amount of bone you have on the back. This is the best fit and fill, and you can kind of play around with it. The really cool thing is I order the CT scan, send it to the company that you use, and lots of them have this technology, and they send it back and they say, this is it. And you just click on it, open it up, and it's already adjusted for it. You can play with it if you want to, but most of the time, that company and the rep that you have a relationship with kind of knows what you like to do, gets to know you a little bit, and he says, I think this is best.
So we're in this ever-growing world of technology, and so we're talking about cars that are going to drive themselves, potentially fly. I'm hearing this, and I'm going, oh my gosh, I mean, does a machine eventually replace doctors? I mean, looking out 20, 30, 40 years from now, what do you guys sit around in the break room and talk about?
I mean, I'll never say never. I mean, but I don't, you still have somebody that has to make the decision to make game time decisions. Oh crap, we just cut through this. We got to fix that. Yeah. That kind of stuff is, there's no robot that can do that.
Sure.
Well, so, I think about, 20 years ago, to qualify for a hip or knee replacement, it automatically was somebody that was 60, 65, 70, right? The age of the average patient was definitely older than what it is now. I mean, you find, like, with major shoulder injuries that you're leaning towards shoulder replacements sooner than maybe you did 10 years ago because the technology is so much better versus trying to just patch them up and get them through.
Well, that's a good question because there's still this survivorship of components. So hips and knees are getting out 20, 30 years, but we don't have that shoulder replacement. That's it, man. You're done. It's going to last you 50 years. We don't have that.
Yeah.
So you're talking about survivorship of 15 years, maybe longer. So the patient you're referencing, yes, the parts are better, the fixation's better, the components are better, so we can do it in a younger person. But there's really been a lot of advancement in that salvage type operation. Like, hey, you're a young guy. This is what we can do. Well, you'll actually have a really highly functional surgery until you need a shoulder replacement. So you take, like, I had a guy last week that's 54, and if you replace their shoulder at 54, and he's a big dude, weightlifter, active guy, his shoulder was just trash. So he needed a replacement, but he's 54. If you put one in and he continues to do what he wants to do, well, you're going to get another one. And really the difficult thing in joints is if you need another one, it's harder surgery.
Yeah.
I put a component in, it gets loose or whatever happens, there's going to be bone loss there. So now we're going back in and it's not the same environment. We've got to come up with a different way to fix those parts. So like in a shoulder, in a 54-year-old, are you going to replace it in a highly active guy? Well, there's been advancements in surgeries there where we can do other stuff to get you more time.
So talk about that a little bit, right? Because you talked about shoulder salvage. Never heard that term before. When you say that, I mean, are we talking about use of biologics? Are we talking about use of cadaver grafts? I mean, talk a little bit more about that.
Yeah, you mentioned two things that are common. They're really common. So you can, the use of biologics is, we talked about this earlier, it's promising, not proven, but there's a role for it. There's a lot of medications that we use primarily in the knee, like hyaluronic acid, that have applications in the shoulder. It's not approved by insurance a lot of times, but there's good use of it. Mm-hmm. And then, so those are kind of like non-operative things, biologics and whatnot. Platelet-rich plasma, bone marrow aspirate, amniotic proteins. I hesitate to use the word stem cells because that's a catch-all term, and oftentimes they're not really truly stem cells. They're more like mesenchymal cells, and that's biochemistry that is beyond me. But that's non-operative treatment, and there's stuff like you mentioned, cadaver grafts and stuff. So like you can do resurfacing a lot, where you're going to take the humeral head and go ahead and do your standard kind of take the head of the humerus off and put kind of a more standard replacement. Although now we've got these stemless humeral replacements. So literally you're just lopping off the ball and putting a metal ball in place. We figured out how, hey, we don't need a stem to go down the shaft for stability. We can just put the head on. We figured out how to fix it, and it'll be stable. It won't loosen. And then on the glenoid side, which is really the challenge in shoulder surgery usually, on the socket side, you can resurface that. You can lightly ream it and take away all the bad cartilage and arthritic areas, remove the spurs, leave it. You can actually take a dermal allograft, dermis from a cadaver, whether that's a human, bovine, whatever, and take this thick dermal allograft, cut it to the size of the glenoid, and then fix it in there and buy a guy time. Really, that stuff's, it's like rapidly advancing.
And are you buying somebody a year, or are you buying them 5 years? Does it depend on the patient?
We think 10 years. We think
really?
10 years with that resurfacing type stuff. That's what I told the guy that we did last week. I said, hey, I think we can get you 10 good years out of the shoulder. And then what you've accomplished is by replacing the head and just resurfacing the glenoid is that if you go back, or if you have to go back, now the bone is still preserved. So now there's still this good bony vault that I can then fix a normal standard glenoid replacement to. So I haven't sacrificed anything. At least that's the thought and theory.
So, I hear some of this stuff as a guy who's in healthcare, but, obviously not a physician. And I question, man, is this like way out there, or is this kind of in the middle of how your peer group is thinking and acting and doing? I mean, what do you think? I mean, are you consider yourself an early adopter or a?
Well, unfortunately, I'm part of a fellowship group of guys. When I did that Stephen Hawkins Fellowship with Dr. Hawkins, and you become part of the Hawkins Society, which is all his former fellows. Okay. So I'm on this email chain where every former fellow is on there, and it's constant weekly. Hey, what do you do with this? And so then you've got all these guys that are at the front of this field saying, I've had 23 of these, and this is what I did. First 10, I did this, failed miserably. Second 10, I did this. And these are big names in shoulder surgery that I'm on an email chain with. I'm not one of these guys. I'm a part of the family. So I'm abreast of all this information, fortunately, on a very personal level with all these surgeons. So, and then I work with guys at the Carroll Clinic, like Dr. Burkhead, who's
He's been around a long time.
And he's seen it all.
Yeah.
So, and then, there's just constant literature pumped out and stuff. So I would say it's at the forefront, but any guy that's really paying attention and wants to practice well and wants to take care of his patients well, you got to have knowledge of that stuff. Yeah. You got to be paying attention to it, And sometimes you'll see guys that come in and they're like, oh man, why did they do? They shouldn't have done that. I mean, you don't say that, but you're like, man, there were other options, and some guys don't know, But and with technology and stuff, it's that information's it's all out there.
Yeah.
Fortunately for me, I'm a part of this Hawkins Society, where it's just like anything that comes up, like a crazy case that somebody posts, like I'll save it, and then it comes to your office. You're like, man, I got that email. You go back and check.
It becomes part of your library, right?
Yeah.
This is the case. And then you reach out and call the guy. You're like, hey, what did you do here? So this resurfacing thing that we did last week, it was a chain of emails that had come up recently. And you could just pick up the phone and say, hey, how did you fix that dermal allograft to the socket? And they walk you through it, and they tell you and say, okay, that's what I'm going to do. And a lot of times in the OR, you're making adjustments yourself. But
sure.
So I don't think it's far out there.
Yeah.
I'd say it's leading edge, but if you're not on that leading edge, then I don't think you can call yourself.
If you're not ahead, you're behind kind
Yeah,
of
there
thing.
you go. Yeah.
Interesting. One of the things that I think about too is, we've talked all this time about, surgery itself and the components and all those things, but we really haven't talked about rehab. About, okay, now surgery's done.
Yeah.
Right? Now it's time for the tissue to heal, for the range of motion to return. I mean, how much, obviously surgery plays a role, but how much of the outcome is dependent on the patient really engaging in the prescribed
Physical therapy.
Yeah.
and rehab.
I tell them all the time, look, my part takes 2 hours. Your part takes, 6 months. So it's essential, right? I mean, it's just, we can do all the fancy stuff we want, but without appropriate rehab and buy-in from the patient, they're just not going to do well. And I tell folks all the time, whether it's ACL surgery or rotator cuff surgery, look, I know how to do this and do it well. A lot of people do. But if you don't rehab it appropriately, when you end up with a stiff knee or stiff shoulder or lack of strength or whatever, I mean, it doesn't matter how good the surgery was, you're not happy. And if they can't get back to what they want to do, well, then what was the point of doing the operation in the first place? So it's key and it's huge. You got to have good therapists around you, and there's tons of quality therapists in the Metroplex, no question. So, and that stuff it's a lot of buy-in from the patient,
Mm-hmm.
So it's a huge part of it.
You find, I've spoken to some surgeons where they almost have a kind of a pre-screening process where they're trying to identify their, I hate to call them bad apples, but non-compliant patients.
Yeah, sure, yeah.
Right? I mean, is that something that you're mindful of when you're looking at doing surgery on somebody, especially a complex shoulder reconstruction?
It's difficult because you've got, standard office visit, 15, 20 minutes, complex stuff takes a lot bit longer, that you have a very short amount of time. So I'm trained to figure out, okay, this is your shoulder, this is the problem, this is what you're going to do, or here's your options, 1, 2, 3. You try to pick up on that. You try to understand the patient a little bit, pick up on the personality. I'll tell you where you find out the most is after surgery. You put a big whack on them, and then all of a sudden, you're like, oh my gosh, I should have never touched this person, it's not all the time, but every doctor in every field of every specialty
I've had that experience.
has these patients that they're almost on the list. You're like, never should have operated on that person, And so it's real hard to figure out beforehand. You'll get some idea, like nowadays with this opioid crisis and pain medication stuff, that's an indicator that, so there's this whole statewide, information bank where, I can look you up and you're going to have an opioid score essentially. And it'll show you.
Really?
This guy's he's filled 20 prescriptions of narcotics in the last 12 months.
Is that standard operating procedure?
Yeah. And
Wow.
so as a part of the opioid crisis, each state is required to kind of keep track of this. So any narcotic that you prescribe is registered with the state, and you've got to keep up with it. And you'll get a score. You'll get an opioid score. And you just, on occasion, you'll go in there and you'll see that if the patient's like post-op, they're calling every 2 weeks for pain medication. If they're 12 weeks out, they should be not taking this at this point.
Mm-hmm.
And so, and there's lots of triggers. Like sometimes you'll get calls from pharmacists that say, hey, I've got Joe Blow in here and they're trying to fill a narcotic prescription and this is their third one in 3 weeks. I'm not going to give it to them. So there's all these kind of
Fascinating.
points where they can catch that. That's just with pain medication. So to answer your question, how do you pre-screen them is pretty difficult. I mean, you kind of have an idea of personality-wise, just,
Yeah.
But-
Well, and it's just medicine in general is becoming so measurable, right? The payers are starting to move into this outcome-based compensation model or into these value-based care models where they're measuring you guys based on how few resources it takes to take care of the patient and get them to the finish line, right? It's part of the reason I ask that, because it seems to be on everybody's mind.
Yeah, that one's a hard one because, like, on one hand, you'd like to be able to say, compared to somebody down the street, hey, I do a better shoulder surgery than that guy. So on one hand, you'd like to have numbers and outcomes to say, look, I can prove it.
Yeah.
Here's my sane shoulder score compared to that guy's. And that's not public knowledge. It's not like there's, now it's just Google reviews. So,
Yeah.
I mean,
Yeah.
That's your outcome measure is somebody's judgment of you on internet, right?
Did they like your personality?
Yeah. So the outcome on one instance is like, well, it'd be nice for a shoulder surgeon, knee surgeon, sports guy to say, look, my outcomes are really good. Here are the numbers. And that's difficult to explain to a patient because they don't have knowledge of those outcome scores and whatnot. So there's, on one hand, you're like, hey, that'd be valuable for me to prove that I'm better than this guy.
Yeah.
It'd be like, why is Whole Foods better than Central Market? I mean, I don't know. It's just like, it's like trying to prove to the customer, if you will, hey, we're better at this than other people. On the other hand, it's a third party, an insurance company, Medicare, government, forcing this down your throat. And you mentioned using less resources to get good outcomes. Here's your 30 grand, do the knee replacement and the rehab and the care, and that's all you're going to get. If you can do it for less than 30 grand, you keep the rest. If it costs you more, then you got to pay it.
Right.
We're not going to pay more than that. So that's a frustrating thing, because everybody's different. Now, some of that's standard care, reasonable, accepted standard of care. They've got lots of data, especially on joint replacements.
Yeah.
Hey, by this time they should be doing this time. But it does get a little.
Well, it gets a little bit more gray when you're dealing in, complex shoulder reconstructions and, variations of that procedure. And
At the end of the day, what you can control is, do you take care of the patient? So if they're coming back with problems, are you taking care of them? Or you just not. And so for the most part, in complex cases, outcomes or not, whether it's like, if that patient is happy with their experience and you're taking care of them, and addressing their problems that they may continue to have, I mean, that's good practice.
Yeah.
So
fascinating stuff. And what I heard there that's interesting to me is it goes back to, you don't always in life get what you pay for,
right.
But there are so many folks out there that want Bentley level service at Kia prices. And so I feel like that's really the predicament that you guys have gotten in is you get squeezed into this box. You want a Bentley outcome, but you guys want us to do it with Kia prices. And it's very, very difficult to do. So,
that's a good point. I mean, it's, it's.
Sorry, Kia.
Don't cancel our show.
Your new title sponsor. That's difficult. I mean, I think at the end of the day, the best doctors just take care of their people.
Mm-hmm.
It just sucks sometimes when you're forced into, as you mentioned, that box, and you're like, well, this is all I can do because your insurance is dictating it, or what do they call it? The episodic care, where, like I mentioned, here's what you get for a knee replacement. That's it.
Yeah.
So it just can get frustrating.
Should we segue and talk a little bit about golf?
Would love to.
Yeah, I heard you say Bryson D Chambeau. It's funny you mentioned him because I was texting my brother last night and I was watching his driving range session on Monday afternoon. Yeah. And it was hurting me watching him do what he did. Did you see VJ stopped and watched the whole thing go on? And which VJ didn't watch anybody hit golf balls. So let's talk about what he's doing.
Yeah.
Obviously, he's put on a bunch of weight. He's bulked up. He's trying to hit the ball further than anybody, take lines that nobody are taking. Can his body hold up long term?
Great question. So we talked about this a little bit earlier. And you're a golfer and you play collegiately and play at a high level. I don't know if you play.
I played at a high level, not collegiately, but yeah.
Okay. So
He still beats me out of a lot of money on the golf
but
course, but
I mean, y'all played for a while, so
Yeah.
you probably have a good swing. Even the best swing, you're going to have problems, right?
Yeah, yes.
Whether it's
Stress.
elbow, back, shoulder, whatever. I mean, you're going to get them. So even the best swing, if you play long enough, you're going to have problems. So now this guy's like, all right, I'm going to gain weight and I'm going to swing as hard as I can. And I'm going to just increase his swing speed. So his muscles and his anatomy allows him to do that. But is it going to hold up? He's going to develop problems at some point. But for him, you got to give him credit. He's a pretty good golfer beforehand, winning tournaments beforehand. But he said, I'm going to do something different. And this is what they were talking about on the Golf Channel. Like, I'm going to do something totally different that nobody's doing. And he's getting results. Is it worth it? I don't know. He won the U.S. Open.
Yeah, we'll see. I guess what I struggle with is, I think it was Hogan that talked about our bodies. When you think about a golf swing, it really does everything you shouldn't do to your body. I mean, the golf swing is so, it's like everything, all the motions and movement are really opposite of what our body wants to do. And now you take these guys like him that not only is he swinging violently at the golf ball, but he's having 3 and 4 and 5 hour range sessions, then playing 18 holes of golf, then coming in after the round and doing it for another 2 hours till dark. Les has got to be more there. I don't see it working out.
I don't know. How big is he, guys?
He's 270. Yeah, 260.
6'2",
6'2",
6'2". I mean, it's not like he's 6'5".
So if you went by like body mass index, I don't know what a 6'2" guy is supposed to weigh, and body mass index is not exactly totally accurate, but like, okay, here's your suggested weight for this frame.
Yeah.
And then, so, all right, well, I'm just going to tack on however much weight he gained. I'm going to tack on it. So forget the back and the elbow and the shoulder from the swing. What about his knees just walking courses?
Yeah.
So we tell people all the time, heavy people that come in with knee problems, you're like, look, you've got a knee problem. I can fix it, but unless you shed weight, it's not going to hold up. It's like driving on a tire. Your tires are wearing out and you got a pickup loaded down with cinder blocks. It's like, look, if you get rid of the cinder blocks, it'll take pressure off the tire.
Yeah.
So, that'll be a factor in him too, is potentially his knees and just all that walking. So
it's interesting too. I know, since we're on the injury report for this week, Brooks Koepka is going after it when he's told to take 8 weeks off. And he's pushing it week 3, week 4 right now.
Yeah.
Which I find fascinating. But it's the Masters. I mean, it really is the greatest week of the year. Have y'all been?
I've not.
I thought you'd been.
I've not.
No. Have you been?
Twice.
Yeah. What years did you go?
The year I was in fellowship, the year that Trevor Immelman won. And
08.
then I went back. This would have been in the last 4 years. I can't remember who won that year, but saw a practice round. And won real live round. So it's unbelievable. I mean, it is really the mecca for golf for sure.
I heard someone last night.
Even just a sports fan. I mean, just got.
Oh yeah, you don't even have to like golf,
right,
to like the Masters. It's like a spiritual awakening when you come walking.
Yeah, anybody that's ever played golf would say that. And then you haven't been, but like when you'll go someday, you got to go.
Yeah.
And you'll just walk on. You're like, this is like TV does not do it justice.
Mm-hmm.
Yeah.
It's just this up and down, hilly bumps everywhere.
That's being able to watch the Masters in November with no fans.
Yeah.
To be able to see the through lines.
Yeah, that was different, right?
Mm-hmm.
To be able to actually see what's on the other side.
Mm-hmm.
And have some depth perception and be able to see some of the hills and some of the movement. I mean, that was, I think that helped the average fan, including me, be able to understand what we're looking at. But, I'm really excited to see who's got a chance to win. I read on the way over here, or I heard on the way over here on PGA Tour Radio that Justin Thomas has more tickets and more money bet on him than any other player in the field, only to be followed by Jordan Spieth.
Really?
Interesting.
Yes.
Well, just this afternoon, I'm actually
I guess with Jordan winning last week.
The Masters favorites as of this afternoon. DeChambeau flipped with Dustin Johnson as the favorite. He's at 19-2, and then Jordan Spieth and Justin Thomas 11-1 odds, which is pretty interesting.
Jordan, I mean, he plays well there, even when he's not playing well.
Golly, I mean, DJ was 8-1 in November.
Mm-hmm. There's some another guy flying under the radar this week too that they were talking about last night. I don't particularly care for him, but Patrick Reed is hitting the ball so good. Yeah. Nobody's talking about him, and
nobody likes him.
He plays that course pretty well, and he's a great putter. He's actually number 1 on the tour putting right now, which is or strokes gained putting. Yeah. All right, couple of quick trivia questions. I tried to pick out some Masters trivia that none of us would know. So we talk about this incredible place, Augusta National. How old are the Magnolia trees on Magnolia Lane? Anybody have a guess?
I don't know. How long? When did the Masters start?
It came about in the 30s.
38, okay. I think.
I would say, I'm just going to say as old, whenever it started is when they planted them.
CJ's thinking.
So 90 years, basically. If they started in the 30s, I say 90 years.
I don't think they're that old. I think the Magnolia trees were maybe put in and replaced in the 90s.
They're 160 years old.
Oh my gosh!
Isn't that incredible? And
was it a Magnolia plantation?
It wasn't. It was a certain flower that they grew there. The family that owned that property, but the right in front of Rays Creek, in front of 15, is that correct? It runs all the way down and through 15. They used to use that where the balls would roll in. That was basically protection from the Indians that were invading that land back in history, which is kind of interesting.
That is cool.
There's only 2 pro golfers that are current members of Augusta National. Who are they? Actual members. Not I want a green jacket and I can come play, but are actual members.
2 professional golfers?
Mm-hmm. You might know one of them.
Jack Nicklaus.
Yep.
Is one of them.
And the other just retired not long ago off the senior tour.
Ben Crenshaw.
No. John Harris, of all people. And then you mentioned this person a little bit earlier, who's the only president that was and still is a member, technically, of Augusta National.
President of the United States?
Yeah, a former president.
Former president of the United States.
There's only one president that's ever been a member there.
Am I allowed to answer?
Mm-hmm.
Eisenhower.
Correct. You got it. The tree.
Yeah.
Oh my gosh.
That is a small world. I mean, those are random facts about Augusta National. No doubt about that.
For sure. We wanted to feature the latest and greatest equipment. And I had to personally go to a golf club that I just put in my bag last week. I put a new Michael Ray, will give him a shout out. He finally guilt tripped me into putting a 3-wood in my bag. And now I'm wondering why I haven't had one for a long time. But the new Sim 2 equipment across the board is really pretty awesome. Super high launch. They moved all the weight down to the bottom of the club. It's
Sim 2, that's the brand?
It's TaylorMade Sim 2,
TaylorMade.
yeah.
TaylorMade Sim 2.
So for those of you a little bit higher handicappers, you can go to their Sim 2 Max hybrids and driver, but super forgiving, and it's fun hitting a 3-wood 300 yards. Really is.
Like you really need that at Prestonwood.
Yeah, I might out hit you with my 3-wood. It'll be fun.
You can't make any putts.
I'm learning how to putt too.
Drive for show and putt for dough.
That's all I got on golf today, guys.
That's right. Well, Dr. Scovell, thanks for joining us.
Yeah, thanks for having me.
Hopefully this was as enjoyable for you as it was for us.
Yeah, it was good, man. Just BSing about orthopedic surgery. So
yeah, sure.
So I'm at the Carroll Clinic, and I'm in Frisco and Dallas. I don't know if I'm allowed to say that.
100% you are.
Yeah. We're open for business, so come see me. I do sports medicine, shoulder surgery as well. So.
Yeah. You are allowed to say whatever you like about your practice. We'd love to promote you and
thanks.
Recommend that people come see you. I think, I like the idea of being able to know more about a person that I'm going to see, especially when I'm hurt. That's there's a degree of comfort in knowing the person behind the medicine, and that's part of why we're doing this. We want to bring that to our audience too. So
well, I appreciate that. Yeah, I think my experiences in college football and being around that stuff and being around big time teams, D1 stuff is like, I think have a good feel for, all right, what can we do to get this guy back? Because that's really what a lot of people are interested in. Just what do I have to do so I can continue to do this?
Yeah.
So I think I have a good idea that, that's what we're looking for.
Carroll Clinic's such an incredible institution.
100 years old this year.
It's awesome.
Yeah.
The best of the best. My mom actually got operated on their Achilles heel reconstruction. Dr.
Yeah.
Curry there. So
Yeah, I do that too. Did one yesterday.
awesome.
Yeah.
Well, there you go.
Yeah.
She's getting around.
That's no fun. I had
so
one of those.
from a horned frog, a badger, and a red raider,
There you go.
we're gonna call it a day.
Sounds
So,
good.
Gents, thanks for making time, and
Thanks.
look forward to our next opportunity to talk soon.
All right, good deal.
Bye.